know what to stand, so those are my conflicts of interest. So actually, when I was starting to prepare this this talk, I was very happy because I thought it was a quickie. I didn't listen to Katie Katuni properly when we discussed the topic, and I thought the title is "What should we do in those instances?" And I thought, well, this is a one-slide talk. We may discuss about that, but probably we all agree that in dissection we should stand only if needed, because we know it's complicated. In stenosis we probably should stand, and if there's a clot, even a hard clot, we should remove it with thrombectomy. But the question is, do we know what to do? And this is a whole different story. And we heard a lot about clues of ICAD and things like this, but I must say that in my clinical practice, especially at night, usually I don't have a clue. So this might be two reasons for that. Either I really don't look properly at pictures at 3 a.m. at night, might be, or we actually do have a couple of patients, probably more than 50%, where we don't have clues. We don't have good collaterals on CTA, or we don't see them. We don't have hyperdense clot and any other things we talked about. So this is one of those cases. Actually, we didn't have a clue. I just went in and it was a proximal M1 occlusion. So there was we put the stent retriever inside. We have some kind of, however you call it, flow channel or whatever. You didn't see any compactation of the stent retriever. Actually, it was a stent retriever that is not fully visible. We all know that there are different stent retrievers. So in some, you just don't see that it's not a proper opening at the site of occlusion. We did one retrieval without any change. We did another retrieval without any change. And then there's the question what to do. So I'll go very quickly on the slide. So we all know about first pass effect and the effect of like recanalization during the first few passes. It's not only about the time, so how fast we are, but we know that after 3 futile recanalizations, the chance that we add clinical benefit to the patients declines very rapidly. So there's something, well, it's not magic, it's clinical, but there's something special about recanalization during the first 3 effects. So in this case, let's say we did 3 passes in best clinical practice, in my opinion, right now. It's some kind of combination approach, meaning using a stent retriever and an aspiration catheter to like create a vacuum locked unit. But this is prone to discussion. So knowing about like first pass effect and data about the first passes and being futile, does it mean that I can go home and, like we say in Germany, make Feierabend? So we heard about that. Of course not. The most important predicting factor for good clinical outcome still, even after the 3rd pass, is the recanalization. So we have to go for recanalization. So actually at that moment when I go in, even at night, when I hurry because I want to go back to bed, after 3 futile passes, probably there's the right moment to step back and start thinking, at least for a moment. And usually when we talk about European patients, it's mostly, like in 99% of patients, probably either an embolic or an atherosclerotic, meaning ICAD problem. And when we look now from this problem from the theoretical side, and we start with the ICAD underlying pathology, it's straightforward that neither a stent retriever nor an aspiration catheter, not the combination of both, will solve the problem. We might remove the acute thrombotic lesion on top of the stenosis, but we will not cure the stenosis, and probably the acute thrombotic occlusion will reoccur quite frequently. This is what we've seen through all the cases. And permanent stenting in ICAD is the solution, I believe. We heard about angioplasty, but some kind of mechanical removement of the stenosis. Actually, this is what we did in this patient. We didn't have any clues that it was underlying ICAD, but anything went fine, so we were lucky in the end. And the patient was discharged without any clinical problems. So the idea to do permanent stenting in remaining occlusion in acute intracranial occlusion is not new. So we have the first publication from the beginning of the 20s. But when you look at the data, like from 2016, there's more and more publications, something like return of the stent, and actually all of them show quite good clinical outcome when you compare those patients that have been stented to patients where the vessel remained closed. So actually, actually, so we used the Credo NeuroSpeed combination for our intracranial stenosis, even in acute stenting. So we heard about technical stuff. I won't repeat this. And Paul Stracke, at the time he was working with us, did a retrospective analysis from 3 German hospitals, so altogether 60 patients that were treated in acute occlusion with the Aclino at that time and NeuroSpeed system. And he could show that even like in this real world data, how you call it, we could achieve at least doubling the good clinical outcome when you compare those patients to the TK0 patient. So we heard about balloon-mounted stents, so I read those articles with high interest because I believe that we might benefit from something, from a new balloon-mounted system that's especially designed for intracranial stenting, but this is up to further development. And I'd like to show one case, one straightforward case, so quite young, male patient with a very low NIH stroke, right-sided hemiparesis that was initially admitted to an external hospital with this images, so aspects of 10 and the proximal M1 occlusion. And actually he was transferred to our hospital, arrived there a couple of hours later. Actually, when you look at the NIH, when you read the neurologic report, they say the patient got much better. I would say he didn't decline. NIH 3-2 is the same. The images were the same, so still high aspects, the same occlusion. And actually at that time, I was not in charge. The colleague decided not to do anything, keep the patient on high blood pressure and keep him on stroke unit under surveillance. And next morning happened what was a high chance to happen. So even under high systemic blood pressure, the patient deteriorated significantly, now with an NIH of 5. And at that moment, we decided not to take him to angio directly, what you actually could do, in my opinion, but to do an MRI. And what we see is a very small infarction on flare. We see an occlusion in native time-of-flight angiography, and we see this little lenticular infarction, and we see little embolic but hemodynamic infarction. We took the patient to angio. At the beginning, those images aren't that good. We start usually with no sedation when it's possible. It was possible in this patient. So we see this M1 occlusion. And the one thing I want to point out is that the patient had good collaterals. I believe you know what I want to show you further on. So we did one pass with solitaire in that case. You see that you have achieved flow with the solitaire deployed. No recanalization after retrieval. And then my first TED question, this might be too easy, but I was asked to put in questions. So I ask you, what do you think? What is the underlying pathology? What to do next? I think this will be a quickie. For anybody who doesn't know about Nimbus, I'll be talking about that. Yeah, I believe we can... Still surprise? Okay, very interesting. So in all the questions I put in, I believe there's no wrong or right. I just can show what we did actually. Now it's still, the longer we wait, it's maybe like with an intervention, things change. The longer the wait. But now, like PTA and Stent 1, I believe repeating is something interesting. Actually, I think we could continue with the slides, please. Yeah, what we did, with no saying that this is right and repeating would be something that is wrong. We went for PTA and Stent at that moment. And why did we do this? So we saw on CTA and an angiography that we have excellent collaterals. We saw that we have very little infarction, despite that the patient had an M1 occlusion for a very long time, and we have hemodynamic lesions. So altogether, and I believe this is what we learned today, this points to ICAD as an underlying pathology in this case. And actually there's just to undermine this, there's one nice paper from the Korean group of predictive value of computed tomography, and this is what Myros actually told about, but only pictured, that when you have a branching side occlusion, this will rather be an embolic occlusion. On the other side, when you have a truncal type occlusion, this will rather be an ICAD underlying disease. And actually, when you look at the images from the publication and when you look at the CTA I've showed you, it's actually the same image. So we have a typical truncal type occlusion that points to ICAD. And so we went for PTA and stent in this case with a credo heel, so no change in medication in our institution at that point. And everything looked fine, the vessel remained open, and in this case, we and the patient were lucky, so only this little infarction remained. So I'll skip this because we talked about medication, and in my belief, we should use glycoprotein antagonists. We don't have cangrelor, the same. I'm from Hamburg, as Bernd Eckert is, it's too expensive for us as well. When we go back to our schematic drawing, so on the one hand, we have the ICAD as an underlying disease, and on the other hand, let's say it's an embolus. And I don't want to be or sound arrogant, but I would say when I do 3 passes in like best medical practice and really concentrate and do my best and still don't achieve recanalization, maybe there's not something wrong with me and my technique, but with the thrombus. And we do all know that what we get out with the stent retriever don't look always the same. So we have a range of thrombi, they look different, they are composed of different materials. And actually, when we look at this from the histopathological signs, there's a range of what we do like and what we don't like. What we actually do like, if we could choose, are red thrombi with a high red blood cell concentration, and what we don't like are fibrin-dominant thrombi that have a very low red blood cell concentration. And why is that? Probably might not be the only cause, is the lower the content of red blood cells, the higher the friction is, and probably because of this high friction, it's very difficult to pull the thrombus out of the occluded vessel. So what to do? Actually, industry went in first and designed a stent retriever that is especially designed for those hard clots. The group of Adnan Siddiqui in Buffalo actually looked at it in a very eloquent model, so no in vivo testing, and they could show that at that time this device was called GCE, Geometric Clot Extractor. Now it's the Nimbus device that is commercially available, at least in Europe. So they looked at this model, they put in a fiber-enriched clot, and then they could show that they could retrieve the thrombus in every case with the GCE and in only 7% of cases with the solitaire. So this is something nice and interesting. In vitro information. So there is a prospective clinical study that actually finished recruiting patients, the Spiro study. I hope we will have results soon because we finished recruitment like a year ago, and I believe it will be very interesting what the study says in the end. So what else to do? People report that they do double stent retriever technique as a bailout because it might be better to get hard clots. We do this only sometimes. There's no real data about this, so this is just given to discussion. There's one interesting innovation that I never had in my hands. I can just report this. There's a guide wire. It's called Clotilde from the Sensome company. I have no disclosures with them. And this is a guide wire that's about to measure the clot compositions due to impedance. I can't tell you more. They're running a prospective study, and they want, in the end, to tell you how high is the fibrin content in the clot. So in the end, tell you what kind of stent retriever you should use. I'm actually just very curious how this will work and what the study will show. One case, looking at tough clots. So this is an elderly woman with high NIHS right hemisphere stroke due to M2 occlusion. And this is the angio, so still M2 occlusion. And what the colleague did, so 3 recanalization attempts, 2 times with solitaire. Then when we don't achieve recanalizations, we try to change like the design of the stent retriever, so from solitaire to embotrap or from embotrap to trevo or however, and still no recanalization. And actually actually then the colleague had to go for a decision, and still there's no right or wrong. I can just tell you what we did. And I'm curious what you say, what you would do in this case. Okay, so very interesting. Just repeating, if we wouldn't have waited this long, would have won. So we did like 3 passes, and like in our institution, we think that even continuing when you think that you have done everything correctly probably won't solve the problem. So just repeat, PTI and stand is even. I think we might continue with my slides. Yes, so what we did actually was PTA and stand. What I have to disclose that at that time we didn't have the Nimbus on the shelf. So the study was over and we didn't have it in our normal consignation stock. So we didn't have any other possibility. So we didn't want to repeat. And this is what the colleague did. So first PTA with the smallest neurospeed, first given aspirin, and then putting in the credo heal. And this is the immediate result. And what you see that at the side of the occlusion, you see some irregularity, so some sludge, whatever you call. So the colleague waited 10 minutes, progressive occlusion, almost complete occlusion. Agrastat was only given at that point. Probably it would have been better, and with our standard operation procedure, to give it like at the beginning of the stenting. I don't know if would have made any difference. And in the end, the vessel remained occluded, so no other attempt to recanalize this, and the patient remained with a large infarction and, well, didn't get worse, but didn't get better as well. So the question is probably, what did we stent in this case? Do we know? So we didn't have any real clue in advance, but when we think now, so M2 is a very unusual location for ICAD, especially in the German population. So it's very, very rare instance. We don't know. We had no clue for dissection. I'll be talking about this. So in the end, could it have been a hard clot? And it's not about snowplowing effect, but no hard clot is as hard as a stenosis, as an ICAD. So probably what we have is like we can put the clot apart, but then we have the clot protruding through the like very wide meshed stent again, and this is what probably led to this progressive occlusion in this case. So probably we don't have data about this, but when we would have known it's a hard clot, probably permanent stenting wouldn't have been the best, or at least with a low density stent wouldn't have been the best idea. So if it would have been up to me, actually the talk would have been over. I actually didn't want to talk about dissection. And why is that? I don't have a lot of experience with only intracranial dissection in acute occlusion. So when I was preparing the talk, I actually remembered only one case from the last 10 years, and then I looked in our database and I actually found one other case. So probably we have more, but cases where we actually in the end in the report stated this is probably due to dissection, only 2 in 10 years, and we do like over 200 thrombectomies a year, so this is a very rare. So when do we think about intradural dissection? So mostly those are young patients. They may present with headache. When we talk about intradural or solely intradural dissection, mostly takes place in the posterior circulation, the vertebral artery. And when you look at imaging, of course, there are imaging clues like an intimal flap, double lumen, string of pearls. But actually, I almost never see this in intracranial imaging, especially when you do like fast stroke imaging. And even like authors of very, very good studies state that all those imaging clues are only very, very rarely seen in intracranial vessels because they are so small. It's something different when you look at the aortic or something else. So things are easy when you have a cervical dissection that of course, we know it's only rarely, but it can continue to the intradural space. So in this case, we know, of course, the intracranial stenosis is due to dissection, and we go ahead in this case and stent it because it had hemodynamic implications. This is the one case actually I remembered where we stated that this is probably an occlusion due to dissection. So this was a young man, one red flag. So it was a martial arts fighter that actually had a fight the night before and was kicked at the head and presented like firstly with headaches, second red flag, nausea, and then had progressive symptoms, and next morning he had tetraparesis. So we first did MRI, so you see this large pontine infarction, and you see on the MRA, you see the mid-basilar occlusion. So fortunately, this patient had very good collaterals to the basilar tip. Therefore, he was still awake. So we took him directly to the angio suite. You see this mid-basilar occlusion. We put in at that time the solitaire AB. So you realize this case took place some years ago. And you see recanalization. Why having the stent retriever in place? Then we did one retrieval attempt, and like progressive weighting over time, you see that at the site of the occlusion, we get like slow re-occlusion. And in the end, I believe it was after 10 minutes or something, we have occlusion again, maybe something like a tapered vessel. I don't know. So we went in and put in the solitaire again, now really thinking we have a dissection at this place. And you all remember this was the first solitaire that you could actually detach, something that was quite handy in some instances. And the patient in the end, so he had a large infarction at the beginning, but in the end after rehab he was fine. So I'd like to conclude with one case that's actually a little bit out of the topic, but it happened like 3 weeks ago, and I learned a lot because I wouldn't have thought that it would work like this. So it was quite a young woman. She was admitted with a very low NIHS. We made MRI. She had M1 stenosis, so very low NIHS, only one clinical event without best medical treatment. So we put her on double antiplatelets, and then 2 days later she had a severe deterioration with NIHSS of 14. So we did an MRI, and we see this perforator stroke, but we see lots of embolic and hemodynamic strokes. We still see this M1 occlusion, so we took her to angio directly, and what we see here is this long stenosis, probably Mori B or C, and of course should be treated. So the colleague in charge went on for PTA and did the first PTA, and we talked about one problem with the neurospeed. In some cases it's too short, so actually in this case the 8 millimeter is not enough for the whole stenosis. So second PTA, and after second proximal PTA we have this perforation. So balloon was inflated, pressure was put down, protamine was given, and then the question is what to do now. Okay, very interesting. So actually, I told you I was not in charge. I think so, like we say, it's like retrospectively thinking, it's always difficult, but I think I would have continued with balloon occlusion as well and would occlude and delay it and wait and do longer occlusions, but I think we'll continue with the slides. The colleague decided to do something different to PTA and stent. And actually the idea behind that was that what he did was a transmural dissection with the balloon. And he said that there is some kind of flap, and maybe with the stent it's possible to like put the flap against the vessel wall and integrate the vessel wall again. So I was very suspicious if this would work, but like one credo was placed, then another telescopically, then PTA was performed, and in the end we had like occlusion of the bleeding in 5 minutes. So I don't want to say that this will work all the times. There's no data about this. I haven't seen like a case like this a second time, but this is like one idea in this situation how you could treat the problem. So of course we have immense contrast extravasation.
Was it just stenting or PTA, another PTA in stenting?
So this is after just stenting, you still see a little bit of extravasation, and then another PTA at the site of extravasation, then the extravasation stopped immediately. Yeah, so both. And so contrast agent, of course, large stroke, the vessel remained open, and the patient was discharged to rehab with high MRS, unfortunately. So I'll conclude with take-home message. Do we know what to stent? Usually we don't know, or in some cases we don't know. So in this meeting we get very many clues to like say in advance, but there will still remain some situations where we don't know. Still revascularization is crucial. If there's clues pointing towards stenosis, calcified vessel, truncal type occlusion, good collateral, small infarction, even hemodynamic infarction, probably stent-assisted PTA, or only PTA, how we learned today, is the way to go. Dissection, very rare, at least in our institution. Young patient, tapered occlusion, intimal flaps, usually hard to see on cross-sectional imaging. And when we talk about hard clot, we might have a branching type occlusion that is futile in like best practice when you do recanalization. Thank you very much.